Shared, okay. All right, so I want to welcome everyone to the fifth Bike Fitters webinar, then in which we've been discussing various topics relating to bike fitting. Each of the panels for the first four have been different. So we have different individuals who have expertise in specific areas that we've invited to share their views on bike fitting in general. But today we're going to focus on medical bike fitting. And before we start, I would like to have each of the panelists introduce themselves to you, and we'll go around sort of clockwise. So we're going to start with bike fitness coach Rick Schultz.
Okay, bike fitness coaching here. I've been bike fitting for about 13 years, put my own program together, which kind of fed a lot of the IBFI new instruction that's coming out. My course was put together with me and my daughter, who is also a PT. She works currently at Red Bull Performance Center as the PT for the skateboard and the surfing team. Going forward, we're just going to get more and more into the medical bike fitting. We are accredited by the APTA and CPTA to give CEUs to PTs for our course. And with that, we have usually every one of our courses, about 6 or 7 PTs attend. A lot of interest in bike fitting for continued level of care and performance. So with that, that's it in a nutshell.
Okay, well, thanks for that. Happy, and please introduce yourself.
My name is Happy Friedman. I know most of you in person. I know some of you as a voice on the other side of a telephone. Excuse me, they told me I have to close the door behind me. Okay, you got it? And I invited most of you here. This is a discussion that we've been waiting to have for a long time. There's lots of mysteries to what medical bike fitting is, since nobody has defined it, at least nobody who's medical that I'm aware of, or a lawyer or a court. It's a standard out there that we haven't decided on. And I figured I'd invite some people who have stakes in the business to have a discussion of what would make it medical as opposed to non-medical. I am not a doctor. I'm not anything other than a bike fitter. On the other hand, I've been doing this for over 40 years. So I have a fair amount of experience, and I've done it in a hospital environment. So I'm going to let the rest of you introduce yourselves. You're far more qualified as far as being medical than me, or you have life experiences that make you of value to this conversation. We're all going into new territory. None of this has been discussed before. We're about to have fun.
All right, thank you, Happy. How about you, Brent? Can you introduce yourself? Unmute. It's okay, don't worry.
Let's let Gene go first because it'll make more sense.
All right, that's fine. Go ahead, Gene, unmute.
All right, I'm Dr. Jeannie Williams. I am a physical therapist and own Quest Health and Performance. We're a sports medicine clinic, multidisciplinary with physical therapy, bike fitting, and mindset coaching. And then also endurance sports coaching, actually doing training plans and things like that for athletes as well. So we're working on becoming a one-stop shop for our endurance athletes in the Knoxville, Tennessee community. With that, Brent is our local resident licensed race mechanic, taking care of the bikes while we take care of all the people. With that, so we jokingly said when we started this that he was the chief bike mechanic, I was the chief human mechanic. With that, so we've now got a couple of additional PTs on staff. One is training to become a bike fitter. He's already a PT and a licensed USAT coach. So my role is I'm PT, bike fitter, and coach. So.
Did you have anything? Yeah, go ahead.
So to follow that up, my name is Brent Williams. I am Jeannie's better half. I am a USAC licensed racing mechanic. I'm also the co-founder of the Professional Bicycle Mechanics Association, so I'm very involved in the cycling and the mechanical industry. And right now I'm talking with USAC about possibly being an instructor at the Racing Mechanics Clinic this year, although I'm not sure that's going to happen because of conflicts with my day job, if you know what that is. But my job basically is to support Jean in what she's doing from a fitting perspective from the mechanical side. And because we're working on, of course, bicycles that are very high value and to a certain degree fragile and complex. And so that's where I come into this.
Okay, well, that should be interesting. Jason, can you introduce yourself, please?
Yes, thank you all for inviting me. I'm Jason Ballo. I'm a physical therapist for about 25 years, as well as I've been doing bike fittings for approximately 20 years. I also am a professor at a university in a physical therapy assistant program for orthopedics and kinesiology.
Okay, good. How about you, Wayne?
I had a 37-year career with Shimano Bike Components and followed by the last 2 years with SRAM, and I'm very recently retired. I had a very successful bike racing career with 3 Olympic teams and wound up in the Bike Hall of Fame and a lot of other awards, and currently famous as Peter Stetina's uncle for the younger generation, because all of my racing was 4 decades ago in another century. But regarding bike fits, I have always analyzed all riders just visually to see if they are within the parameters of how all the other pros look. And then I did several hundred bike fits for injured and rehabbing vets and first responders from 2011 to 2018. And it was very interesting because I had to take into account all their injuries and physical limitations that completely changed what would normally be an efficient bike fit. So I have a great deal of interest in seeing how the medical application and potential medical liability bleeds over into bike fits.
Oh, yes. Okay. And Peter, can you introduce yourself?
Hi, my name is Peter Moley. I am a physiatrist and a physician at Hospital for Special Surgery in New York. I've known Happy since I started here. I am a cyclist, not a great cyclist, but I do ride a lot of miles, and take care of a number of cyclists as patients, and then prescribe biking to patients for various disease processes, either narrowing or spinal stenosis, arthritis of the joints. It can be very effective, but I was very excited when Happy asked me, because I think understanding the fit and adapting to different patients is often misunderstood, and while cycling could be beneficial, they get on a bike and are very uncomfortable. I think the world needs to look and how do we better serve those patients.
Okay, and I'll briefly introduce myself. I am a professor in neuroscience at the University of Florida. I work remotely and am teaching graduate students in master's programs and others about neuroscience. And so my interest in cycling comes from the fact that I love to ride. I'm an avid road cyclist and virtual cyclist in Rouvy. I use it all the time. I have taken a bike fit course, and I am interested in moving a little bit more in that direction when I retire, which should be soon. Hopefully, I mean, yeah, like in a semester. So I'm in my last semester, but My interest is really as a cyclist, and I have some interest in neuroscience underlying some of the bike fit. So I approach it more from nervous system than biomechanics. So, Wayne, do you have something to add?
Yes. For over a year and a half at SRAM, I was pursuing a special project reaching out to a lot of the leading bike fitters that taught other bike fitters. And I pulled Rick Schultz into this project as well, trying to figure out what products specifically would be most important for the bike fitters that SRAM could provide in terms of pedals and cockpits and crank lengths. And I think you'll see that moving the needle in the near future for more options that the bike fitters desperately need. But it's hard for the largest companies to effectively tool up to provide short cranks, as clearly probably the number 1, 2, and 3 most needed option at this point.
Okay, well, that's important information. I'm an advocate for short cranks. Okay. I want to start the webinar specifically with Happy, since he was instrumental in organizing this. And the first question really is somewhat broad, so we're going to try to narrow it down and see where it goes. But it's asking like what the major differences are between medical and professional bike fitting. And each of you probably have your own viewpoint on this, but I'm going to start with Happy, and then we'll see where we're going to go from there. So if you
Well,
can do that, that would be great.
sometimes they're the same thing, sometimes they're very different. I consider anything medical, to use the word medical, or to imply a medical clinical background, as using and working with somebody who is a medical professional to start with. I consider it to be collaborative work because I'm often part of the team to get their patients better, and sometimes they're part of my team to get my patients better. It goes both ways. We have some issues like vocabulary, and there's a little bit of a caste system, so we don't always talk to the people we should be talking to about what we're doing. We also have a scope of practice issue. What is mine and what is theirs or somebody else's? So medical fitting versus standard fitting, I would say the two meet wherever I'm standing, and the line on the road runs between my feet.
Okay, that's pretty good and concise answer to sort of laying out what some of the differences are. Does anyone else have any comments to begin with in this conversation on the differences? He mentioned the language differences. In other words, how each of the fitters might talk to each other, their clients. And also he mentioned some of the common ground or caste system, which isn't common. In other words, there's a priority or ladder. So go ahead, Rick.
Yeah, I would like to hear from Jeannie and Jason, since they're in the medical field, and maybe Peter as well. What is their definition of a medical bike fit? I think if we can start there, then we can start getting one level deeper into what the differences could be. So Jeannie.
No pressure. Get to go first here. All right. So, kind of the way I explain it to folks is, as a healthcare provider, as a physical therapist, I'm doing a physical therapy diagnosis with any of my PT patients that come through the door. And so I approach bike fitting as a diagnostic process with that. And so my brain is always working to integrate, okay, what's their medical history? What's their cycling goals? What are their complaints? And approaching that just like I would a PT patient in the clinic, going, okay, here's their subjective, here's their history, here's the objective findings from an exam. Okay, now what's the assessment? What's the plan? And so basically just working through that process is how my brain approaches bike fitting, whether that makes it a medical bike fit per se or not, but that's how I approach it and look at it as a medical process. And then I explain to my clients that sometimes it's a bike issue, sometimes it's a body issue, sometimes it's a hybrid of both. And so my job is going to be to tease out which one it is and what's the most effective and desirable goal for them and how we achieve that. Because honestly, there's some people that are like, fix the bike as much as you can. I don't want to do any extra work off the bike. I just want to go ride with that. And so those aren't going to be folks that I'm going to say, okay, you need to do these strength and these mobility things, because they're not going to do them. And that's not what their goal is. That's not what they're looking for. They're looking for adjust my bike and get me as comfortable as you can there. And if I can't hit all of their bike fit goals mechanically, I'll have that conversation with them and say, okay, here's the limits of what we can do in terms of bike fit. Now we need to go off the bike and work on this list of things. And these are the barriers that are keeping you from hitting those goals with that, because sometimes their comfort on the bike can be because they don't have enough core strength stability. They don't have enough mobility. They're not willing to invest in short cranks if they've got mobility limitations with that. And so it's a matter of teasing out what they're willing to do and what they really need.
Okay, let me ask you something. When you say that you can, so you're sort of able to talk to them as a patient, presumably in that context. And so that allows you to do some things that you've just talked about that are pretty different from what a standard or bike fitter might be able to do. Can you define just briefly the line where you see the line between what you do and what a professional bike fitter would do? In other words, yeah.
Knowing that some of the mechanical education programs out there teach a physical assessment as part of their training, I do think those lines get blurred and there can be some, shall we say, overreach of boundaries by some of the mechanical fitters that try to start telling bike fit clients, hey, you've got a leg length difference, or you've got hip joint mobility, or you've got hip joint issues, or you may have arthritis and things like that, where they're taking, okay, look how far their leg bends up and this will tell you this. They don't have the clinical background to say, okay, they have that limited mobility because of this and this. And, in neuroscience, you've got all of the motor control and adaptability things that happen in the system. They can't put those pieces together. They can explain if this, then this is what I've been taught, but they don't understand the whys.
Okay. Well, that's what I suspected. But we'll hopefully get into that discussion a little bit more in a few minutes. Wayne, you've had your hand up there for a bit.
I had this discussion before this symposium with Happy, and I realized that every single professional bike fitter is unintentionally crossing over into practicing medicine to some extent, because from my perspective, if you're going to enjoy cycling, it can't be painful, and it's difficult for cyclists to differentiate between joint pain or physical exertion pain. But if your saddle is the wrong saddle, or the height is wrong, or you're developing knee pain or a problem because your cleats are drastically misaligned from your neutral position, then any change that somebody comes to me and says, I've got terrible knee pain and I can't ride, or, getting numb where I'm sitting and got this terrible back pain. As soon as I do a bike fit, I don't know how you draw the line at all between, I'm not saying you've got arthritis, but I'm saying, okay, you have an overuse pain problem because you're misaligned, and there's always two ways you can address that. One is that you can adapt the bike to where the rider is at that current moment in time so that they can hopefully be pain-free and injury-free. Or two, you can also try to improve the core strength and other things. And it doesn't take a medical degree to see when people don't have core strength and, their weight and everything else so influences their bike fit that they can't get a proper fit. So I think that as this becomes more popular, cycling and more people doing bike fits, and there's such a wide variety of training and no certification really, we have a serious problem of at what, you could call almost all of it crossing the line.
Okay, Peter, what is your viewpoint on this?
So I think kind of building off of what Jeannie and Wayne have said, every good bike fit is somewhat of a medical bike fit. And then you can derive from that, like how much you know and how you understand core and mechanics. And we do a lot of work on understanding hip and lower limb mechanics and how that could affect you in day-to-day life or cycling. So a good bike fit should include a good evaluation. But if I was to kind of simply define, I would say a professional bike fit is a fit to improve performance for a cyclist who wants to achieve a greater degree of performance and maybe less pain while they're doing that, as far as in the positioning. And I think a medical bike fit for me is we're trying to use the bike as a device to allow somebody to move and get a cardiovascular workout and even correct some issues like back issues that are better when you're seated and a little bit forward. So I have patients who need to be exercising but can't, because they can't walk on a treadmill, they can't walk outside enough distance to get their heart rate up for a period of time. And we could use the bike to do that. But oftentimes they go and buy a bike at a gym store, and it comes with set crank lengths and set distance, and they're on big saddle, which is sitting on their hamstrings, and there's just so many things wrong with it. Then they come back and say, I didn't really enjoy being on the bike. So it would be nice if we, there was something to say there's a better bike or a better way to look at that. Bike could be useful for patients who have been injured or have deficits, who can't walk. And so I kind of look at the medical side as a bike fit for somebody who needs the bike to exercise well other exercises aren't possible. That'd be my medical bike fit. And I think a professional bike fit includes a medical evaluation. You need to understand the mechanics of the patient, but at the same time, you're really looking at comfort and performance more so than the ability to exercise.
Okay, so you actually have a very distinct, well, there is a difference, I think, from maybe, maybe I'm wrong, but Jeannie, Jean, you seem to be, you and Peter are kind of in a different group, at least from what I can hear. So Peter might actually have patients who have other problems, medical issues that are fairly serious. And he's trying to get them to be able to exercise efficiently enough to help rehabilitation from whatever disease they're battling. And then you, G, might be working with people who maybe don't have a medical condition so much, but may have other issues. Well, they're medical, but I mean, is it disease oriented or is it something else? Or is the goal simply to get them exercising, or is it getting them to ride a bike more as a cyclist rather than as a treatment? So what I see is you're treating or you're getting, and both lead to better cycling experiences for your clients. That seems to be a goal. But where you start with your client seems to be very different potentially, although there's a line there too, I can see between. And so we get into another issue that I want to start discussing in just a minute after I let Happy chime in here. But there is another concept we need to talk about. So, and I need to get Jason involved here shortly. Okay. All right. So Happy, what do you have to say?
I actually have a very simple line of division. Most bike fitters are doing what I would call accommodative work to try and make you more comfortable. And when you pass toward medical and clinical, you're dealing with injury or disease, and you're actually working on healing as being the distinction. That you know there's something that you're trying to fix.
Okay, I would actually agree with that. I mean, if we can all agree with that, there's sort of a focus on healing to improve quality of life, perhaps, and then there's improving comfort for a rider who's already riding, but could be more comfortable and more efficient. But I still see a lot of gray lines, so like, okay. One of the interesting things about all bike fitters that I've had a chance to meet through these webinars is that there seems to be borders sort of between, or boxes that are created around different groups of fitters. And so what we get into is this communication issue, so that perhaps those walls, you might call them glass walls, but a goal in the bike fitter community as a whole might be to enhance communication between all the different types of people involved in fitting, the philosophies they adhere to, and then actually form a cohesive group. I've always been a really strong advocate of cohesive groups. So, anyway, I'd like to hear from some of you about why you think there's a sort of a segregation among the fitters out there, in terms of maybe who they talk to, who they're comfortable with. Is there a group of you that thinks you're more superior than another? And if that's the case, maybe that's not good. But those are things I'd like to address a little bit, to see if the two groups that are represented in this discussion, medical versus general, could somehow work more closely together in a productive way.
Start with Jason.
Sorry, Jason. Okay, Jason, go. That's a tough one. Hopefully.
Yeah. Well, I do. My thoughts parallel Gene's quite a bit at that.
Okay.
I think the medical versus bike fitter, I can't separate that in me when I'm fitting a person. You know, my knowledge doesn't split down that line at all. I think when we look at the different groups of us, it's all about training, and the terms we use, scope of practice, like knowing when to say I'm at my limits of my scope also, and I need to send off, whether that's from a medical end, a mechanical end, you know, orthotics that are deeper than I can go in my knowledge base. And I think that's the important part for all of us to work on that line between, because I think the line is very wide and gray at times. I don't phrase my fits ever as medical fits versus non-medical fits. I don't truly phrase it that way between the differentiation of my fits. But I think ways at the industry we can improve that is trying to bring knowledge levels up. You know, one of my hallmarks when you see motion capture are body points, where are people locating points on motion capture. And sometimes our data, we may have numbers, but they're not relevant numbers if I'm putting, you know, the knee access anterior to the kneecap, the patella. So I think just education levels and trying to even that playing field out also would help.
Okay, so I hear something about education. What about organizational? How do you guys actually organize? So if you get into a situation where you're kind of saying, well, this isn't a problem I can address, but I know someone who could. I mean, are those links made, or are you guys kind of, what happens to that client in 90% of the cases? Do they get directed to the right person? Do you guys know who the right person is? Or can you find one? That's a bigger question, it seems. Let me see. I'm going to go ahead and ask Wayne, but I think Brent, can you answer that? You're the mechanic, so you're actually in an interesting place.
Yeah, that's actually why I was going to chime in here,
Go
because
ahead.
I sort of married into the medical side, if you know what I mean. But the interesting thing is my dad came from a background of nuclear medicine, so I've been very closely aligned with that my whole life. And the interesting thing was when we started the Professional Bicycle Mechanics Association, I had the worst experience in my life of hurting cats because I very quickly realized how different, how desperate the different factions within the mechanical community were. And from a bike fitting standpoint, even though I already held bike fitting certifications when I went through my racing mechanics license clinic, it was interesting to hear some of the instructors there basically saying, we don't need no stinking doctors. We can do any fit that's necessary with a level and a plumb bob and a tape measure, you know? And literally they were saying, we can do everything. We don't have to send anything out because we're the mechanics and we know everything. And I'm sitting in the back of the room going, you don't know anything. And so there is that kind of perception bias, if you will, based on your environment that starts to tell people, oh yeah, I know all the things there are to know. I've been through a couple of 4-hour classes on whatever this topic is. And when I talk to mechanics about bike fitting, it's interesting to hear guys that are doing, in essence, overglorified sizings, and they're literally calling them medical bike fittings. And I just gnash my teeth. How do we change that perception? That's a topic for an entirely different podcast, because we can talk about that for days.
Yes, you could. And I think that's you have to do that to get to the solution, I think. And I'm going to ask Wayne. Wayne, go ahead, and then I'll come over to Peter.
I had mentioned the survey that I did, and it was interesting because I was reconnecting with a lot of close personal that I've known for decades, whether it was Ben Sirota or Porrick or Dan Emfield, Paul Swift, all the fitters that are teaching other fitters. And you get fitters in a room and they'll argue endlessly. And it seems like there's more disagreement than agreement on the optimal way, whether retool works or it doesn't. Every leading fitter says it doesn't matter what tools you use, or if you don't have any data capture at all. If you're a good fitter, you will get a good fit. And if you're not a good fitter, it doesn't matter what you're using for the system, you will not get a good fit. And so that was the one thing that everyone agreed on. And I think that's really important to understand the relevance of training and experience. And then to go back to something that Molly had said about if I put my amateur podiatrist hat on. I have used to make my own orthotics. I learned very quickly from road to track, different cranks. If my Q factor changes, if my inversion or eversion changed, every little change that I made was a completely different neutral position to prevent injury. And so there was no, everything had, there was a solution for every situation. But then the question becomes, which one is optimal for racing and performance. And so that was my definition of where I was going with myself as a guinea pig. And I was very fortunate that I was fairly adaptable, but I could still see major performance differences. So I just wanted to throw that out there in reference to where we were just talking.
Okay, so basically it brings in the idea that the desired outcome will influence the focus of the fit. So if you're interested in racing versus maybe casual cycling, you're going to have a slightly different goal at the end point. But
And
both of them, yeah,
different disciplines,
right,
triathlon,
right.
mountain bike, gravel, everything is different. So, and
Also, let me kind of open the door that nobody wants opened here. There's another dynamic that we're really not talking about. In a lot of cases, when it comes to bike fitting, there's the profit motive. And so you end up skewing your diagnostic direction based on what can I sell the client. And that drives me crazy.
Right. Well, isn't that sort of the add-on or something like that? We haven't discussed that. We might get there today. Actually, we do sort of when you get to legal issues, but we're going to put that one on hold for a second, and we're going to ask Peter to contribute what he was thinking about a few minutes ago, if you still recall what that would be.
So I think with with Gene and Jason, working in the medical field, a lot of times with physical therapists, terminology is not consistent. I actually have a physical that works with me, and we read notes from physical therapists, and I have her interpret some of the things they're saying, and abbreviations are different, terminology is different, thoughts are different. And I think if you're looking at bike fitting, my guess at the highest level, it's also different. When you get these people in a room, they'll use different terms for the same thing. And I think that makes it very confusing. So I think ideally you want to come to some final conclusions. I think you have to start with a base level of what do we agree on? What's the terminology we agree on? And then how do we take from the highest level bike fitter to the mechanic who's fitting, and at least provide the client with a good experience, because we all pretty much agree on the same things. And here's the same terminology. If you see X, you're going to either do W or Z, but at least you're going the same way, and we can all talk to each other. The abbreviations are the same. We haven't, I think in medicine, we really haven't done that, but I think it's something to think about when you get into this is, could we all agree on one consistent terminology? I think the ball moves forward a lot faster when you do.
I think that's a huge pipe dream. Seriously, you can't get people in the PT industry to agree on terminology, even though they're doing the exact same thing. You can't get people in the bike world to talk about the same terminology using the exact same parts. Brent, what is it? The bottom bracket standard, and there is no standard because there's a bazillion of them.
Any part in the mechanical bike world that says there is a XYZ standard is a contradiction in terms.
Yep.
Well, that's what makes the cycling industry so fun, is that there's so many standards to pick from, not one but many. And Brent, to address your other question, or the terminology you want to use in what your previous comment was, Dunning-Kruger.
Yes, that's exactly right. Confirmation bias.
Yes.
Hey, Happy.
Hi there.
Hi
I've
there.
been sitting and listening, and the vocabulary has been skewed for this crowd. I intentionally picked people who I thought could talk to each other. And as far as solving problems that go beyond this room, they all have my phone number.
Okay. Well, if I were approaching this as a novice bike fitter person, my first inclination as a scientist would be to compile those lists of these terminologies and cross-check them, and then see if any of them mean the same thing, and then make some compendium that somebody could look at, because that gets sort of at this glass house thing. So you all know what terminology may be confusing to another person in another slightly different area of fitting, but if I was interested in finding out, the breadth of the terminology and what terms are being used in what context, I'm not sure I could actually find that. Probably not. So I think some of the problems that you're talking about, the pipe dream, yeah, it's a lot of work. But it might be worth doing as sort of a foundational step. If you want to kind of unite across a little bit, those that are younger or maybe more interested in investigating that could certainly look at that. And that would be a way to cross-educate them. So we have this problem in neuroscience quite a lot. And so we have, books and books. But, how you talk about something is so important to being able to tie links between individuals. You can't do it if everyone's speaking something different. So that might be something to consider for a future project. And that said, I would like to move forward a little bit. There's something that's kind of unfortunate about most things in this current time. When someone wants to help someone with a service, and there's always somebody who decides that they didn't like it, or they decide that what was given wasn't correct. So we're going to venture just slightly into some of the legal issues, and I suspect that they form boundaries and perhaps prevent some fitters from staying in bike fitting if they have a terrible experience. So we want to talk about some of the things the risks you might have if you don't do a good fit. And then when are there risks? In other words, I think Happy said there's a Good Samaritan law. I didn't have time to look that up, but you can, in some situations, avoid getting into serious legal issues. But I can certainly see where you could definitely step in it. So who would like to start with a discussion brief of the legal issues that maybe they're familiar with that surround what you do as specifically related to bike fitting? Anybody? Okay, Happy, go.
Okay, one of the biggest problems is you do a perfectly adequate job and they don't like the results. I once had a gentleman who, in order to make the bike fit him, we would have to have small wheels, a very short crank, and we still had chainring hitting the front wheel because he was so inflexible. He had to sit like he was driving a tractor trailer, upright with a round steering wheel that he could turn without moving his back. And that was totally unsafe and unrideable. And I told him, I'm not going to sign off on this bike to send to a builder because it's dangerous. 3 years later, I get a subpoena from small claims court. I didn't do a bike fit, is what he's claiming. I did. He didn't like the outcome. Fortunately, I got a judge who was a cyclist who understood the problem and threw it out. But these are issues that you can deal with or will have to deal with at some point when somebody doesn't like what you did. There's also the other end of the spectrum of where you send bikes back to bike stores. There was one day I sent about $30,000 worth of new bikes back to a store that had sold them to one of my clients. And when I looked at them and said, they don't fit. And the reason they didn't fit, he was built like a T-Rex. And these bikes had top tubes that were long enough so that an orangutan would have trouble reaching the handlebars.
Okay, the visual image there is quite amusing. But Does anyone else have any comments about this in particular, or how you avoid? I mean, avoiding risks of wrongdoing, at least in my mind, could potentially compromise what you're doing. Or do you just stop and then send them to somebody else? I mean, how do you do this? Anybody?
Well, part of the way that you mitigate risk in a case like that is you approach it from a legal standpoint. So are you having your clients sign any form of waiver beforehand? In the racing mechanic world, we are told that our mechanical services provided, and if we have to render aid in the case of a crash, that we are covered not only by USAC's insurance, et cetera, but we're also covered by the waivers that the riders are signing.
Okay. Well, how many of you as fitters actually use that kind of document? Okay, a few of you. Okay. All right. That's probably a good idea in terms of protecting yourself. How about you, Peter? What do you have on your mind?
So just on a medical side, you know, we're kind of not a fitter, but exponentially our risks are higher and we pay a significant amount of malpractice. We take a tremendous amount of continuing education, and the number one reason for lawsuits is actually human interaction. It's how it went, it's the follow-up, it's everything you said, it's how you treat the person. When things go wrong, you're on the phone with them. Those things make a much bigger difference. I know a lot of, you know, doctors who are very good and have been sued multiple times because they just don't feel the necessity to call back their patients or things. I know doctors are terrible and people love them. So that's an interesting, you know, if you look at the legal side of these, oftentimes it's the experience, it's the follow-up, it's when they're frustrated. Do you get on the phone or recommend somebody else? But you just make sure you stay in contact. You're less likely to get sued, at least in the medical world.
Okay, well, that's true. I think that's true for what I do too. More contact with students is always better. so you know, you can avoid some fairly significant interactions if you just kind of keep on top of things. Although I think as a fitter, it might be tough. Jason?
I also would say from the legal end, it would be relative to what liability insurance you carry and what it is worded as, because I know my bike fittings are done in a separate location than the private practice I practice in, and my insurance is absolutely separated also. So that's another factor there.
And so you separate, you do bike fitting in one location and is it PT or whatever else? What's the other?
Yep, physical therapy.
Okay.
It's a private practice I work for, I do not own. So I
Okay.
do my fittings from within that facility.
Okay. All right. And you actually are able to keep them separate. I'm just
Yeah.
wondering, I mean, so you're doing something with physical therapy and then they want something with the bicycle and they go somewhere to your other.
Yeah, if I have a bike fit client that now I have to take back into the medical realm, I wouldn't treat them, you know,
Oh, I
where
get that.
I would
Okay.
refer them appropriately, whether it's to, you know, myself as therapy or wherever else, other therapists or other medical professionals.
Okay. No, I understand that. So there are, let's see, in addition to, so some of you have already talked about insurance. And I'm not sure if, because of the distinction there, I would imagine there's very different insurance that you might seek out. What would a regular bike fitter, where does their insurance come from? Does anyone know that? or do they have it?
You're
mean-
kind of making the assumption that they actually have.
Okay, I can see that. But if they did,
also-
where would it come from?
It also varies from state.
Go ahead, Happy.
Yeah. It would vary from state to state because each state controls its own insurance regulations. So that makes it a more complex issue.
So
And
what
some
did-
of the suppliers have their own requirements on insurance also, if we're receiving products from them too.
Okay, well, you're sort of being vague.
I
What
know-
products?
One of the suppliers, I forget the minimum, but the minimum insurance policy has to have liability insurance of, I think it's $2 or $3 million, to be allowed to receive product from them.
Okay, and the products you're referring to, can you state something specific?
Bike specific parts.
Okay,
So
okay,
whether
okay.
it's something as simple as a stem or whatever else it may be.
Okay,
But it is interesting in the industry, having talked to literally hundreds and hundreds of mechanics and bike shops over the course of the PBMA work, it is stunning to me how little of the traditional bicycle mechanical side anyone cares about insurance. I've seen so many shops that have no mechanical liability whatsoever, and that just blows my mind because we're working on a device that we're going to hand to a client and they could be downhilling at 60 miles an hour that afternoon. The risk is huge, but it's manageable, and you can cover yourself from a safety standpoint simply by insurance. But it blows my mind how few people in the industry actually do that.
That was one of the things I wanted to discuss on this topic, was kind of the difference between mechanical and medical, and the legal sides of things is, and kind of where I was talking about that crossover initially, is the mechanics that sometimes overstep their boundaries into the medical world, but then the clinicians who overstep their bounds mechanically working on bikes that may not have full mechanical knowledge for safety and making changes to a bike. And honestly, that's where my other half has been gold in my practice, to save my butt more times than not on how to fix something or what can or can't be done mechanically with that. And part of what got me thinking about this was I was having a conversation with another private practice owner in town who had a new PT that was doing a bike fit education course to start doing bike fits. And my initial thought was, great, we've got another medical bike fitter. More people out there doing this as a PT bike fit combination is better, makes it more normalized for the population, blah, blah, blah. But then I realized I'm talking to him and he's like, "There's all the tools." And I'm like, okay. And I started naming things and his jaw's hanging open because he had no idea from a mechanic standpoint what was involved to work on bikes. And so there's a liability piece there as a clinician. If you don't know how to adjust torque properly, you don't know how to put a new stem on safely and make mechanical adjustments there. If you start messing with brakes, any of that, there's liability on that. If you send that bike out and it's not safe mechanically as a clinician, yeah, I'm liable because I was the one that worked on that bike. So that's another huge legal thing that doesn't get covered in teaching clinicians to be bike fitters that needs to be addressed as well in the industry. So.
Rick?
Yeah, so that was every one of my classes I do take feedback from the PTs. And that was one of the things that kept coming up, is that, yeah, I understand the anatomy and that piece of it, but I'm not sure about what to do. You talk about a Torx wrench versus a torque wrench, and what is it? So I've now put together a pre-booklet, let's say, that goes through. It's a 3-day course, but it's going to take 3 days before you take the course for them to actually go through, and we go through is how to adjust the saddle, what's involved with it, which tools do you use, how the differences of the different clamps there are, and we go through in great detail. So when the PTs come in and take the course, they're almost as they understand what is needed. So, but you're absolutely right. That is one piece that's missing on most courses. They jump right into, okay, lay the client on the table and lift their leg up, and how much flexibility do they have? And so that's where most bike fitting courses start, which you're right. They're missing the whole piece of the, well, yeah, but when I get to the point of adjusting the bike, they assume that the students already know how to use the tools and correct torque settings. This is one, well, Wayne left, but this one for Wayne is that you don't know how many of the front derailleur securing bolts, you know, where when Shimano went to the Di2, the front derailleur had so much torque on it now that it can actually rip the rivets out of the frame. And I've seen frames where that's happened to. Brent, you've seen that too. 9 out of 10 bikes that come in for bike fitting, the mechanics don't put the screw in to actually the plate. And I've seen mechanics forget the plate and they screw the screw right into the frame, right through the carbon fiber, trying to keep the front derailleur. So yeah, there's a lot missing on both pieces. I totally agree.
Yep. So it sounds like every bike fitter should have a mechanic, you know, highly trained bike mechanic at
be
arm's length so they can, you know, work together somehow.
And I'd say that's where our gray line is, depends what side we come from. So if you're a pure therapist with no mechanical background, you have a strength on one side, or if
Yep.
you're a pure bike shop mechanic on the other end, you have a strength on the mechanics of that bike. And that's where those worlds need to merge a little bit better too.
That's the opportunity for collaboration, is for the clinicians that don't have that knowledge, is you need to be partnering up with your local bike shops. And then the local bike shops need to recognize when beyond their scope medically in the body to go, hey, we've done all these things to the bike, but they're still having back pain and we've put them on the highest setup we can to get them as upright as they can, and they're still not comfortable. Okay, hey, maybe you need to go see the PT in town.
And that brings us back around to the topic of profit motive. When the bike shop owner says, we're not sending that fit out to anybody, we're going to make $400 on a saddle and a stem and a blah, 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 blah for this guy. Even when the patient is presenting with issues that are far above their pay grade, they think it's only a bicycle. What's the big deal? The fact that this girl has scoliosis doesn't matter. Let's put her on a new saddle. It's nuts.
Well, I have one comment about that. Bike shops have sort of are bemoaning the fact that their customers don't return as often as they would like. And that's probably in some cases because when the customer goes out the door and they ride for a little bit, they decide they don't like it. And usually it might be associated with, you know, cycling hurts or
No.
something is making them sore. So they're not going to come back as a repeat customer. So, I mean, there's sort of this weird little one-way door that isn't working very well. And I hear the bike shop saying, oh, we're going to go out of business because they don't come back. Well, it's pretty obvious why they're not coming back. And it's the same thing for physicians. You guys, when you guys work with patients and do a super job and they're so ecstatic to be improved, trust me, they're coming back. You know, it's not, so it's not rocket science, but I sure don't see, you know, the logic that a lot of maybe the cycling retailers and stores, bike shops, they need to embrace this aspect of cycling a little bit more. Happy.
Well, one of the problems is modern bike design. It's not designed for the recreation rider. Most bikes are designed for pros. Most consumers are not, never will be, and they don't stand a chance of becoming one. But they want a bike just like the guy in the tour room, and they will buy it, and they will then take home an expensive coat rack.
Yes, they will.
The industry has to recognize that all people are not bike racers, and people have to recognize that they are people and mere mortals. I've raced against some of the best riders on the planet, including Wayne. He had no idea I was in the race because his race was somewhere up the road, miles away from my finish. And I was considered to be not bad as a local regional rider. But you have to recognize your own abilities and inabilities. And then you have to look at what the bike is designed for. Are you short-waisted? Does the bike have a long top tube? Are you short-legged? And is the bike too tall? And by the way, selling bikes in New York City to delivery people, you have to find the tallest possible bike. They can get their leg, well, at least one leg over, because they're not buying no girly bikes.
Okay, all
Okay,
right.
when a big man's, but this is the point. People come in with expectations for what a bike should be, what it looks like. And it's totally the wrong bike for them, but the right bike doesn't look cool. And I
Right.
think as an industry, we have to start educating some of our manufacturers about what it is to be a mere mortal and ride a bike, as opposed to contending for a stage in the tour.
Well, I don't see that happening very soon. Because I mean, they're actually moving further and further away from normal cyclists. I was commenting to someone recently that, you know, the images they have in catalogs, or if you look at anything that's selling a bicycle, the seat is outrageously raised relative to the handlebar cockpit area. I mean, it's just crazy. The angle could be as 45 degrees or whatever. And that is what, the naive and or even somewhat experienced cyclist is going to think is the position they're supposed to be in when they're on a bike. So when they go buy one, they have these images in their heads. And that's where they go. So one of the things that I wanted to mention, what do you think the chances are that you would, it's probably not high, would be the first stop for persons interested in starting cycling or before they purchase a bike? In other words, this is all backwards, you know. They go in and get a bike that's not quite right for them, doesn't fit, and then they go through this whole process. It would be infinitely better if the consumer actually had the right direction to start with before they went to the bike shop, because you might not find the bike you need in the one down the street. But that doesn't seem to be something that anybody's really thinking about. And you guys might not have a good way to control that. But I also know that if you ask people on the street what bike fitters do, they have no idea. None. And so that's sort of important too, in terms of sort of addressing the issues of what you guys do and how do you communicate, medical versus professional versus any bike fit. Yep. Jean, go, Jean.
Yeah. So a couple things on that. One is on the previous conversation of language between medical professionals and mechanics and getting a unified terminology. Part of the problem is, and it ties into exactly what you just said, is how does the public view bike fitting and what do they know about us? And for the PTs and the bike fitters in the room, there's an amazingly shared statistic among our professions. 7% of people with musculoskeletal pain will see a PT for their pain. Guess how many people who ride bikes get a bike fit done? 7%.
7, really? Okay.
7%. And the problem is both professions, PTs and bike fitters, all want to fight over the 7%. Instead of going after the 93 and bringing more people into our world to then increase word of mouth referrals. Like you said, happy people will stay in your world. And so part of the language issue is you have to talk to the consumer. You have to talk to, as Happy said, the regular person. And so then you get into terminology issues. We've gotten blasted on social media from, shall we say, our bike snob friends when we have called it a bike seat, because that's what the public understands versus the cycling community that says, but it's a saddle. But if you say saddle to the average person, they think a horse.
They do.
And so if our objective is to get more butts on bikes to increase the industry, we've got to talk to the people that we want to attract, not the people that are already in the field.
Right.
So I think those are where those two things intersect, and where honestly, all of us are missing the mark in all those professions. and why we're not getting more slices of the pie.
I'm surprised about the 7% of somebody in both areas. I'm not sure that if I had some kind of muscular skeletal pain and after I was riding a bike that I would actually know to even go find a bike fitter before.
Well,
You'd
but
be
just like the
surprised.
musculoskeletal pain, if somebody's got back pain, who are their choices? They can go see a physician, they can see a chiropractor, they can go to a yoga class, they can go to a personal trainer, they can go to the stretch lab. All of those things are out there. PT is one of those options.
Right.
And so lots of people are seeking out other avenues to deal with that pain other than PT. And so the problem is PT fighting over 7%.
Okay, yep.
When there's
yep,
93% that aren't utilizing us as a profession for their pain.
okay.
And the same for
Well,
bike fits.
So Jeannie, one step further, once you get the people in your shop, what about terminology? Do you use lateral malleolus or do you use ankle bone when you
Ankle
talk to
bone.
them?
Ankle bone
Ankle
all
bone.
day long, all day, every day. Until they show, if they come in talking my language already, then I will talk to them at that
Yeah.
point. But I'll say, but I'll clarify as I go through to make sure, does that make sense? Do you understand what I'm talking about?
Right.
And
But
you
the
can
only
easily read.
clients, the only clients that can speak her language are going to be someone from the ortho industry, and they're not going to come in to see us anyway because they know everything. Just ask them.
Do I detect some?
What do you
Ooh.
mean?
All right, Wayne.
I have a very different perspective than everyone else. And I start from the 80-20 rule. 20% of the shops sell 80% of the bikes. And I'm in and out of shops all the time, but I don't have time to visit the really small shops, and they are becoming ever more marginalized.
Yep.
So the reason that the successful shops are successful is that they really focus on customer service. People usually do some research and they ask their friends what bike shop, if they have a friend that cycles, they say, what bike shop should I go to? And if they've had a good experience, they'll send them there. And when I'm in these good shops and I watch them selling bikes, they're doing a reasonable job of fitting people. I mean, yeah, some people are going to need more. It's not going to work out, but I think that you're speaking to a problem that is not nearly as severe as it once was, and is sort of self-correcting in terms of shops that just try to sell anything they've got. And yes, it happens, and somebody will have a closeout, and yet the geometry of bikes and the positions that I see going out the door for people that are obviously not fit athletes that want to go fast in a fondo or in competition are really biased towards sitting more upright with a cushier saddle, without sitting a little lower than necessary, because it's easier to reach the ground even if you don't pedal as efficiently, and the bike steers and handles better when you sit lower. So I think that the problems that we've had in the past, where you could just open a shop and make money at it because you could find some local people that want to buy bikes, are that paradigm has shifted.
How
I
does
would
it- Oops,
I
go
would
ahead.
actually argue that a little bit, because as the industry grows, the thing that you see, I don't believe that small shops are marginalized. This is like the mom and pop store having to compete with Amazon. Amazon doesn't put anybody out of business that wants to compete. And so when a Starbucks moves into a new neighborhood, typically what you see is one of two things. The local coffee shops either fold or they grow much stronger because of the marketing level of the bigger entity here, the Starbucks, if you will. And what we're seeing in the industry from the small shops, and I kind of hate to dispute this here, because I'm dealing with somebody that's way deep inside the industry. But we're seeing spectacular growth in small shops because they're catering to the specific needs of the clients over, in essence, the big boxes, the big retailers. What you have to do as a small entity in this case is drill down to what makes your practice, because this is what we're talking about here. You drill down to what makes you special compared to the fitting mills, if you will.
Well, you've already proven my point to some extent. I would say Rick Vosper is completely wrong about the number of stores, unless you're going to count a garage location as service. The small places are doing service because that's all they can do. They cannot compete with product against the larger stores. So I see this as always going to be an ongoing problem. I see it much less than it used to be. Everybody knows that the only way to fight consumer direct is to offer a whole different level of customer service, service on the bikes, service to the riders. And those that don't do that can't be profitable locally. You know, the local coffee shop that gets stronger doesn't get stronger by doing the same old thing.
No, you have to compete.
They step up their game.
Sure.
And so I think, I will say it's not nearly as bad a problem as it used to be. But yes, bike fitters are still underappreciated, and a lot more can be done with that. And I think you're going to see that in the very near future, especially with some of the fully remote computerized bike fits, where one company out of British Columbia has already done over 30,000 fits worldwide, and they're introducing version 2 that's getting positions within a centimeter just by taking a brief video of somebody on a bike using your smartphone and send it to them. The problem is that then when they send you back the recommendation, you're relying on the consumer to actually make the adjustment that's suggested and be able to measure. So it's remarkable what AI technology and bike fitting is doing for the time of the fit, and making a good, not a best fit, but a good fit easily done within 30 minutes and much less expensive. So there's all kinds of revolutions that are just on the horizon within the next 2 to 3 years, just as we've had consumer direct become a successful business model that looked impossible for so many years.
I have a comment about consumer direct. I mean, one of the problems that I've seen in smaller cities is that bike shops tend, and I think this is because they're contracted, but they tend to have one type of bike. And I had this experience mostly with cycling shoes. You know, it was impossible to even try on several different types of shoes in one location to find the one that actually worked. And for cycling, a lot of times there's only one brand that's featured in that shop. And if that's the only shop that's in the town, well, there you are. I know it has to do with some kind of financial arrangements of bike shop owners and who they can actually sell bikes for or have bikes in their shop. But one of the things as a consumer, I would really think would be helpful in terms of improving interest in cycling and availability is to have shops not just be one type of shoe and one type of bike, and that's too limiting. So then if you send them online to go buying, wow. I mean, now there's a problem that everything that comes in to them might be wrong. So, and nobody's talking to them. I mean, competitive cyclists maybe, but probably not. So I just don't know how that happened, and I wish it wasn't the case, but I think that actually hurts the cyclists, and it hurts the fitters, because if you're a bike fitter in a town that has one bike shop and they all sell one type of bike, I mean, you're going to be somewhat limited if those bikes don't fit everyone, which they won't. So not sure how to deal with that.
Yeah, so go ahead, Wayne.
Oh, that trend is also reversing. If you had a direct owned Trek store, of course, then they implemented that it was only Trek brands, and they finally got so much pushback that they're starting to bring Shimano shoes and other brands back in, and Specialized has seen the same thing, that Trek has enough product variety, they can get away with it. Specialized didn't. And so the corporate direct owned stores across the board are starting to bring back more supplemental brands. But that is anytime there's an independent store that is marketing the brand of their store is more important than the bike models they sell, then they will immediately offer a wider selection and use that to their advantage. So that was a trend. It has slowed. In many cases, it's reversed.
Okay, well, that's
Yeah,
good.
yeah. I think what Sue, in my experience, what Sue's kind of to parallel what Sue's saying, or to agree with what Sue is saying, is that there's a brand in Southern California over in Carlsbad that starts with a C, and it's a direct to consumer product, and the people buy a one size, a 54 is a 54. There's no other options of crank lengths because it comes from a country that starts with a G, and it comes in and it is what it is. They're uncomfortable on it. They can't get fit. They talk to their friends. Their friends move the saddle up, down, this, left, right. They go and see the bike fitter, and the first thing you see is that, why is there a 120 stem on this 54? You have such, you're a T-Rex and you can't even reach the handlebars. What are the options at this point? It's a proprietary stem, integrated stem handlebars. Trek was kind of in a problem with some of their stuff with the well, yeah, for $850, we can get you a shorter stem with the integrated bars. So, I mean, what does a consumer then have left to do? Is that one option is one option. It isn't going to fit. And what Happy was saying, it's fit for the pros, it's not fit for the consumer, but they're getting a good deal on it.
Because it looks sleek and sexy and like the pros. That's why they buy
Exactly.
it.
Exactly.
They don't care that it doesn't fit until they realize
Well-
I just dropped $8,000 on a bike that is as uncomfortable as I'll get out, and I'm never going to ride it now.
Yeah. And the
And I
problem
guess-
is it doesn't fit. The problem is not only it doesn't fit, you can't make it fit without spending another couple $1,000s to make it fit. Yeah, that's the other issue.
Yeah, and
Agreed.
I can't tell you how many times in big events that I've been working from a mechanical standpoint that I've come across riders that at a glance you're going, oh my gosh, they're in a terrible position, and you talk to them and they're basically, the answer that I get that blows me away every time is, yeah, but I look good.
There's a
Wow.
lot of monkey see, monkey do.
Yeah, that's exactly right. It's monkey see, monkey do. I want to look like the pros, and they don't see the 140 and 160 millimeter stems on some of those pros bikes to get a really big guy onto a fairly small frame, because that is competitively efficient. Physiologically, not so much, but that's, again, it's a different world. We're talking about at the pro level, there are a different set of rules.
Agreed.
And they're not necessarily going to make you better.
Right.
It's just tradition.
Okay,
Exactly.
so Happy, you had one category. I don't even know how to introduce it, so I'm gonna let you do it. And the topic is myths.
Ah, yes. Myths about bike fitting. First one. It's like a house. You start at the foundation and build up. And for that, I'm going to fall on my sword, because I started teaching that over 35 years ago at the Serrata School, the first school of bike fit. It's a myth. It's not true. You don't have to start at the bottom. I used to start at the bottom, and then I realized I was building a foundation for a house that I had no idea what it looked like. I didn't know if it had a big back porch. I didn't know if it had metatarsal pads. I was building houses based on guesswork. So that's number one. Number two, there are no emergencies in bike fitting. Number 3, there are emergencies in bike fitting. Depending on what
Number
your
4.
perspective.
Number
Okay.
4, let's put a 175 crank on every frame.
There are lots of myths. Longer is better. More
Longer is
power is
better.
better. You know, we have all of these different traditions, theories. There's a book called the Coney Manual, which was put out by the Italians. And in one of the chapters in there, they're talking about INTO. And all the riders they looked at happened to be related and happened to have similar foot types and INTO. Therefore, since they were good, INTO was good.
Well, okay, does anyone else have any myths that you've heard or believe in and don't realize? No? No, I mean the
I have a bunch more myths. One, you need to have a plumb bob to fit a bike.
Retool is the gold standard of bike fitting.
ah.
Well, let me take that one to the
Go
next
back,
level.
go back to the original point of all of the people who teach fits say a good fitter can do a fit regardless of the tools. So the tool is only as good as the hands it's in.
Right.
So retool is not the standard. The fitter is the standard.
Well, but that another myth in the industry is, quote, our blank machine is better than their blank machine. All of the machines are measurement tools when you drill down to the bottom line. But the industry is in the business of making money. And so the way that you do that is you come up with a mechanical device that lets you take the diagnostic skill out. That's the whole purpose behind all of the automated systems is we want to be able to give a minimum wage shop sweeper dude the ability to create a repeatable, relatively consistent product and take the highly paid, highly educated fitter slash diagnostician completely out of the equation.
One of the tools that's used often in bike fitting is a goniometer. Sitting here with a bunch of medical professionals, you can tell us what a goniometer is used for, because it sure isn't bike fitting. Goniometers are used to measure range of motion. Why are they measuring range of motion in patients? They're looking to discharge them from care, and the insurance company wants to know what the range of motion is. So we're bike fitting. Are we looking to discharge our patients, or are we looking to figure out what they're actually doing? Pedaling is not a static measurement. Pedaling is an active activity with many components.
Dynamic.
I know it's dynamic, but not everybody listening to us knows what dynamic means.
Yeah.
So what I'm looking for is to find common ground in vocabulary, and I'm finding my mouth is too big. There are too many words coming out. But anyway, getting back to the goniometer. The goniometer is a discharge tool for the most part in today's medicine. It doesn't tell you anything you need to fit a bike. They're great for swatting flies. So these are some of the myths out there. And I do apologize because I was one of the first people teaching people how to use a goniometer in bike fit, along with a plumb. And then I found out they make great mobiles.
Go ahead, Wayne.
I found out back in 2008 that the retool easily tends to set people far too high. And and I've seen that over the years, that people that take retool training set positions extremely high, even higher than I would set for track use on a sprinter. And when you get to pro road riders, it's no accident how their positions have evolved. They have figured out over a lifetime of development where they need to sit. In 2008, I went up to Specialized for the Team High Road camp, and Andy Pruitt was checking everybody's position. And they had some riders whose names you'll recognize. Mark Cavendish, his lead out rider, Mark Renshaw, multi-world champion, Tony Martin in the time trial. They had some good climbers. Danny Pate was the team captain and just sat on the front for hours controlling races at the time. And Henny Stamschneider was there, ran Shimano Europe sponsorship. And I raced him for years. He was world cyclocross pro champion, and he raced with Le Mans and Argentin on the road, you know, very successful racer. Anyway, the long story short, Andy Pruitt was excited that he improved Danny Pate's position by raising him 2 centimeters higher. And Danny said he was going to try it. And Stamschneider just burst out laughing. He said, that's the most absurd thing. He won't ride that position for 2 days, and he'll be right back where he was. So as I look at riders as a racer, I always studied exactly how they were sitting on the bike, how they were pedaling. And so I noticed everything about their pedaling style and their position. And as instantly as I see a rider go by, I instantly analyze, does that rider look like he fits on the bike? Would I ever see a pro with that leg extension? And if the answer is no, then yeah, the upper body pros are going to be different. Their torso is going to be parallel to the ground for aerodynamics, and they can still breathe. But if somebody is off of that, it's easy to me. I don't need a goniometer. I don't need anything else. I just look at it and I can see. And I did literally hundreds of fits for new riders through Ride to Recovery program of rehabbing people that were going to try and do a multi-day, like in 6-7 days, you're going to ride from LA to Los Angeles, a lot of miles each day. 50 guys each trip, 50 men and women, had never ridden bikes to speak of before. And so I'm adjusting all their positions on the fly. And I'm saying, if you get any pains, if it's not muscle fatigue, let me know and we'll take a closer look. And if you still have a problem, don't gut your way through it, because then you may need some kind of surgery. You may injure yourself. You need to go see a bike fitter if it's still a problem. You need to get diagnosed, because you haven't been riding. You can't just go ride 80 miles a day on nothing. And so what are you going to do? You're going to try to help them. But that's getting back to saying, you know, a good fitter can get a good fit with any tools. Actually, in my experience, you can get a good fit with no tools if you have enough experience of looking at people and having them stand with their socks on the floor and do a half squat and see where they angle their feet, and then apply that to their bike position. And 90% of the time, if you're good at it, you hit it right the first time, and then the other people you try to fix on the fly. Anyway, that's how I got into fitting people, where I very quickly had to realize that if people had a really strange position, if anybody is outside the norm, rather than assume they don't know what they're doing, I always ask them if it's deliberate. I was on a ride once with Robin Williams because of my connection with Lance Armstrong and that team. And he was telling jokes nonstop. I took one look at him and I said to him, I said, Robin, you don't know me, but just looking at you, is that your position, or has your bike seat slipped? And it turned out his saddle had slipped 2 centimeters and he hadn't noticed it yet. But you can't just tell somebody, you know, your position's all wrong. Maybe they have an injury and it's deliberate. You don't know until you ask. I'll stop talking now.
Yeah. So Sue, I think it's almost 2 hours. I think it's a good time to, this is such an important discussion. It might be good to just summarize for the people that are going to be viewing this video, what we've discussed. And I can start, we can go around the table. I heard a lot of good things. I think what I've heard is a bike fit, medical bike fit, whatever you want to call it, a bike fit's a bike fit until you get the person as good as you can on the bike. If they're still having problems, then it's time to go see a medical professional that can take, there's something else going on that the bike fitter, it's way over their expertise, it's way over what you can do on the bicycle. There's another human factor involved in now addressing instead of the bike fit. I think Jeannie brought that up, and Happy and Friedman as well. One of the things my daughter told me is when we were going through, now IBFI on their level 1 has gone hog wild on doing assessments and evaluations. They're spending up to a half an hour, 35 minutes doing this exercise, this stretch, etc. And I asked my daughter, I said, what do we do? Can you put a better program together? And she stood there a second. She said, as a non-medical professional, what are you going to do with that information? You have no training, no certification, no license to actually work on somebody or adjust them to take into account what you're actually looking at to analyze. So one leg goes up higher than the other without the back lifting off the mat. What are you going to do? What is that telling you? So I think there's a lot of teaching and a lot of misinformation, misdirection coming from the bike fitting education companies as putting too much emphasis on evaluations and assessments, evaluating people, what their range of motion is, which gets into the point of, okay, so what am I going to do with it? I don't have the training to go that one step further. That's why the bike fitters, I highly recommend at that point in time, you get a relationship with a PT that understands the biomechanics of what the problems is, and work with them. Tell them what you've done. They'll take it from there, get the person fixed, and then come back and get the bike fit. Then it's a whole system put together. And I think that's why a lot of the PTs are taking bike fitting, because that component, the non-educated, meaning that the non-medically trained bike fitters are way overstepping the gray area and trying to treat people as on what to do because the bike fit doesn't work. Those are the two big things I've taken away from this meeting. So maybe go back through, Brent, what is a couple of big things that you've seen as can summarize what we've done so far?
Exactly what do you mean by summarize? I'm not quite sure where you're going there, Rick.
Well, we've done a lot of topics. We've done a lot of viewpoints on topics. I want to hit the high points so people can basically, we spent probably 30 minutes on the first topic, and the kind of the two big takeaways I got from that was the what is a bike fit? What's the difference between a medical bike fit and a regular bike fit? And as I said, I think a bike fit's a bike fit until you get to the point of the bike fit doesn't work anymore. There's still something wrong. Then it's outside your expertise. Work with a medical professional that can do it. I think Sue brought up another thing. What about bike sizing? That seems to be something missing in the whole thing. You got to get the person at least on the right type of bike. Shorter top tube for people with shorter torso, longer top tube for people with longer torso, etc. Things like that. Big high level takeaways that what we've heard from the meeting so far.
Well, we're in an era now where the industry itself is consolidating products. Once carbon came on the market, you started seeing custom built, therefore custom fit bikes starting to go away. And because of the molding costs for carbon, you saw the manufacturers narrowing their line to saying, we've got, extra small to extra large, and here's the divisions, and you need to pick which one you think you fit. Well, you saw the alloy and fabricators sort of follow the same thing. It's like, why should I build a completely custom bike? I'm just going to build a bike that fits the same thing that the Carbon Large fits. And so you've seen this real shrink in the amount of variability that's out there in the industry. And I know I'm going to sound like a stuck record, but what's driving all of it is profit. And the being in my position of being married to a clinical practitioner makes me hypersensitive to where's the demarcation line between where you're trying to sell a bike to a customer and you're trying to fit the bike to the customer to give them whatever the outcome it is that they want. Do they want to be comfortable? Do they want to ride long rides? Do they want to race aggressively? You know, there's a big spectrum there. But 9 times out of 10, what I see from retail bike shops is, first and foremost, they're going to sell the inventory they have in stock. They are going to, frankly, fib to the consumer and say, oh yeah, you're 5'8". This 64 will fit you great. You know, no, this doesn't work. And it's the running joke between Gene and I when we're traveling together. So many bad bike fits. Anytime we go for a group ride, we're just looking at each other and shaking our heads because nobody, the vast majority of the public, like we talked about earlier in terms of 7%, they don't know about, want to have, or even realize that a fit is a thing out there. And so there's a lot going on in this conversation. In reality, I think we could have taken today's conversation and thought about it a little bit in advance and dissected it down and done a whole nother series kind of touching each one of these topics. But the key thing that we've got to realize is there is a demarcation line between making a simple mechanical adjustment to a bicycle because the rider has an obvious disparity. I'm not going to say an issue. I'm going to say it's a disparity. You've got a large person on a small bike or vice versa. And then running into a client that has a physiological something going on that requires a higher level of diagnosis, which is the key thing in my world. The key issue here is diagnostic skill. Do you have the skill to diagnose what's really going on from a physiological standpoint? And the large majority of the bike fitting world does not have that education.
Jason, summary.
Yeah, I think a big takeaway, terminology, you know, consistency across from the education, and it'd be wonderful if we could all kind of work in the same lingo, if we could all use some of the same standards to measure. But as Gene said, that's a pretty big mountain to climb to standardize it. I think that division of skill set, whether medical or not, knowing that limitation of where we've hit our end and it's time to refer off. I think that's key for everyone, and really in every profession where I've hit the ends of my knowledge limit. It's time to move to the next appropriate person and try to make that referral there. And then I think as an industry issue, as Gene mentioned, and Brent, the 7% rule, you know, we're talking about a small, and the ideal situation is we expand that 7% to a much larger number. And the definition of what is a bike fit, you know, well, I sat on the shop and did a lap around and they adjusted the saddle up. I had a bike fit already. What are you going to do that's different? And that knowledge base getting out, I think that's the other big mountain we have to get over, because when you add that price tag for it with that thought on there, there's a pretty big discrepancy for our consumers too.
Dr. Molly.
So this has been fun. I think that I would look at this at a few levels. One, I think throughout the whole talk that medical, every bike fit has a medical side to it. And I think the better the vision, the better the person is assessing the rider, it makes a big difference. I think that while static numbers matter, I'll tell you that we do a lot of work on understanding cadaveric work on limitations of motion. And then you read articles where the motion is well beyond what could ever be possible, yet that's written down as what they found. And so be careful how you're assessing it. I think these are dynamic things. So I would categorize as relatively stiff, but not, I wouldn't say that this amount of motion will affect you until you put them on something and see how they move. So we put a lot of weight into dynamic assessments because I think they're much more important. So this is a medical, but very dynamic. I think in my mind, there's also a group of people who I think need a medical fitting just to get on a bike and to be comfortable. And we can use that medically for exercise when they cannot do other things. The only other thing I think of is that kind of listening to you and the approach of this, and the 7% is, the golf world has, I think, a higher percentage of fitting done. Golf clubs are expensive, and I think people recognize that, kind of like a bike. But the reason I think they do is because the golf world shows the pros being fit all the time. They're constantly being fit. They have numbers, the spin rate, the distance, and they look at all this, and the amateur can understand it. And you can put it on a measurement system and say, you're in the parameters that we see at the highest levels, and you buy these clubs, and typically that's going to work out a little better than you just bought them off the shelf. And I don't see that as much in the bike world. I think the general consumer walking to a bike store, I think a lot of times is maybe feeling not certain. They're not sure they're going to keep riding. Do you get the right bike? It might be uncomfortable, it might not. The general fit seems to be okay. But they're not looking at like, I want to go to get a bike and I know what the parameters are for success and I get fit and therefore I'll succeed. And I think I would look at the golf world to say, what did they do differently to get people to meet with a pro, get a fitting, standardized numbers, and look at success that way? Because it does seem that they have a higher percentage. I can't think of anyone I play with who doesn't get fit for clubs, but I ride with a lot of people who don't. So it's just a kind of a thought.
We'll go with Wayne, then Happy, and Sue can summarize the whole meeting up. So Wayne, go ahead.
My takeaway was that before I ever start charging anyone for fits, which I never have, even riding by people on a bike trail and saying, hey, you didn't ask me, but my unsolicited 2 cents is that you need to move your saddle up about 2 inches and your thighs won't burn so much when you pedal. I would need to get insurance. And I had never thought about the critical urgency of being well insured if you're actually accepting money to do fits. And that's something that was a wake-up call for me.
Happy.
I'm just thrilled that we're having this conversation. It has never taken place in my experience having these bike fit conversations. Everybody's about their technique or their secret technique or the secret sauce they serve you before you get the bike fit. And so we're actually discussing the business end of it and how we don't relate to other stakeholders in the business that we should be. We need more conversations with fitters, PTs, shop managers. We need to develop a network of non-branded experts. And I use the term non-branded because if you've got a system, you want people doing it your way, whether it's right, wrong, or indifferent.
Yep.
And there are smaller people out there teaching things that are not part of a larger branding, and they don't get to speak at the table. So I think we're getting the beginnings of what will help hopefully improve our profession.
Gene, you want to try to wrap this all together?
I think at the core of it, it comes down to marketing. Because everything that everybody's talked about is how do we communicate? How do we get the public perception? The golf analogy is fantastic. There's one key problem. We can't get the pros on bikes to get fit. And if we can't get the pros to get fit, then we can't talk about the pros getting fit to be the standard for the public to get fit. But that's a whole nother discussion. watching some of them, and you can watch in some of the bike fit forums, the cringes during the tour, looking at positioning with that. But I think a lot of it comes down to willingness to have professional collaboration, know where your boundaries are professionally, stay within them, and reach out when you hit that line. And the reality is we live in a very self-centered world that people aren't willing to make those admissions of, I don't know everything. And until we can get the professionals of the industries, medically and bike fitting, to drop the egos some, this is going to be an ongoing battle. Is it one worth tackling? Yes. But I think it's going to be an ongoing struggle to come to a consensus for the fields.
Well, Sue, why don't you wrap everything up for us? And
Wrap it up. Oh my gosh. Well, I have to start by saying that it's been a real pleasure to meet all of you. Every time I do this, it's sort of like going into a candy store and getting a chance to try things you never get to try. In other words, I get to meet people I probably would not meet. And I get to hear your views. And I think that the issues that were addressed, I think that the strength of the discussion was sort of revealing some of the differences between the different bike fit practitioners in the context that they practice that. And I think bike fitting is an art. I think it's science, but I really do think it's an art. And it's informed by data, but the data don't have to come from machines. The more experienced fitters are actually pretty awesome. So they bring a feel for it. You know, they sense what's supposed to happen. I worry a lot about young fitters who are starting out right now. They're being, you know, inundated by all these fancy machines that, you know, you put in a number and out comes a number. And I watch some of the videos that demonstrate these machines, and I'm sitting there going, I don't think this person that's running this machine knows what's happening. But what I also see is that the customer who's sitting on the fit machine seems to be completely enamored by the fact that it's some kind of computer doing a fit. So there's a bit of a problem there. There's a human element to this that's pretty clear. And so what I hope is that when we do these, that individuals who watch them get a sense of what bike fitters do and who they are. I mean, I think the fact that you all care passionately about having your clients come out with the best possible outcome is pretty clear, no matter how you approach it. So hopefully, I mean, I realize that this was broadly framed. There will be additional webinars that will focus on specific aspects of this. And if any of you have any ideas, you should raise them and send them to one of us so we can consider them. So thank you very much for attending. And I really did enjoy it. I hope you did too. And somewhere in maybe a month, we'll do another one. Okay. So thank you for coming.
thank you.
It was
everybody.
great to meet some new friends.
All right. Well, same to you.
Thank you.
Bye.
Thank you all for the
Bye-bye.
invite.
Bye-bye.
Have a great one.